Ladies and gentlemen, I'm Giuseppe Mercante. It's a great pleasure and honor for me to open the TNT Association webinar on thyroid RFA and introduce Dr. Roberto Valcavi. Dr. Valcavi has been practicing neck ultrasound and ultrasound-guided thyroid procedures for more than 30 years. He did the thyroid ethanol ablation as early as in 1992, started with laser ablation in 2000, went through HIFU and microwaves, and is stuck to thyroid and parathyroid RFA since 2010. I had the opportunity to notice his talent in the Santa Maria Nuova Hospital in Reggio Emilia, Italy, where he served as director of the Department of Endocrinology. After this, he became freelance and in 2020 founded the Endocrine and the Thyroid Clinic in Reggio Emilia. His expertise has been recognized in North America in 2004 when he received the American College of Endocrinologists International Award in Boston in recognition of the advancements he has made in clinical endocrinology and for the benefit of all endocrine patients. He is the current president of the TNT Association. Please, Roberto, take the virtual floor.
The mission of the Thyroid Nodule Therapies Association Thyroid Nodule Therapies Association is an international medical organization focused on improvement and worldwide dissemination of thyroid ultrasound-guided thermal ablation techniques to treat thyroid nodules in a minimal invasive way. Thyroid ultrasound-guided thermal ablative techniques are effective and safe alternatives to surgery in patients with benign thyroid cysts, solid non-functioning benign thyroid nodules, and in solid hyperfunctioning nodules. Among these procedures, radiofrequency ablation, RFA, has emerged as the most effective and with light side effects. This webinar is addressed in particular to thyroid RFA. I would like to introduce Giuseppe Mercante, who is an outstanding ENT and head and neck surgeon, professor at Humanitas University and physician at the Humanitas Research Hospital in Milan, Italy. He's vice president of the TNT Association. We share a lot of knowledge on thyroid patients as Giuseppe worked in Reggio Emilia and Santa Maria Nuova Hospital at the same time when I was the director of the endocrinology department. Giuseppe?
Thank you very much. So this is the agenda of today. I will introduce all the speakers later on. You can have a look that we have probably the most important speakers available at this time in the world, but we will come back on this later. I would like to remember what are the rules of today. This is a webinar estimated to finish in 1 hour and 30 in 2 hours and 10 minutes, including questions and answers. The audience will be kept on mute during the webinar. Questions can be submitted at any time via the Q&A function. We will have a discussion after each presentation, and remaining questions from the Q&A function will try to be answered during the Q&A time and at the end of the webinar. So please remember that this webinar will be recorded anyway. I think that a new era of thyroid management has started today. Numbers are always important to understand things and trends. We have a huge number of surgeons and endocrinologists among over 831 participants from all over the world. I should underline that the topic is of interest also to different specialties, such as radiologists, nuclear medicines, and so on. As you can see here in this slide, yes, as you can see in every corner of the world, there is someone connecting now and interested in RFA. Now, I don't want to take more time to the speakers. We start with the presentation of Professor Gilles Rousse. The title is RFA Technique and Thyroid RFA Learning Curve. But I would like to introduce Professor Gilles Rousse, who works in Paris in the Thyroid and Endocrine Tumors Department at La Pitié-Salpêtrière Hospital. Is also professor at University Hospital at the Professor Lennart Thyroid and Endocrine Tumors Unit, always in Paris. And also he works in the Thyroid Imaging and Pathology Clinic in Paris, France. He is member of the European Thyroid Association and the US Board, the American Thyroid Association, and also the TNT Association. He has been recently involved for the risk stratification of thyroid nodules, developing the European Thyroid Imaging and Reporting Data System, also known as EU-TRADS. And also is involved in laser and radiofrequency ablation for thyroid tumors and in active surveillance of macrocarcinoma. It's a great pleasure to leave the floor to Professor Gilles Rousse. Thank you, Professor.
Thank you, Professor Mercanti, for this very nice introduction. I'm very happy to be with you, and hello, everyone. I want to say thank you to Professor Valcalvi and to thank the STARmed company for allowing me to give this lecture on RFA technique and thyroid RFA learning curve. So let's say a word about RFA technology to begin. So the principle of thermal ablation is to induce a coagulation necrosis over 50 degrees centigrade. And for this, we have at our disposal 4 main tools, which are namely HIFU, laser, microwaves, and radio frequency, of course, which is the main used one and the topic of course today. So a basic physical principle of radio frequency is to use an alternative current which will induce ionic agitation. And from this ionic agitation, there will be friction between the ions and then conductive heat. So the main subject of this lecture is about the RFA learning curve. Here, I'm showing you the volume reduction ratio and symptoms improvement in the first 150 consecutive patients of a single operator at La Pitié-Salpêtrière Hospital. The patients were divided into 5 groups of 30 patients consecutively. So what we learn from this curve is that the volume reduction ratio here rapidly stabilizes after the first 30 patients. And moreover, that the first patients have a wild heterogeneity for their results, and after this heterogeneity improve is less important. And this was exactly the same for the patient symptom. Now, volume reduction ratio and patient symptoms are not the only indicators. And there is a very interesting indicator that is the ablation ratio that was developed by Professor Sim in South Korea a few years ago. So volume reduction is not sufficient to appreciate the efficacy. The ablation ratio is a measure of the destroyed volume, which will predict the risk of regrowth. How do you calculate this ablation ratio? It is first you have to calculate the total ablated volume, which is the sum of the volume that has already been eliminated. You easily calculate that by subtracting the residual volume at the follow-up, at the time of the follow-up from the initial volume, and you add the destroyed volume that is still present, that can't regrow. And I will show you, of course, how to measure it. The ablation ratio, then, you divide the total ablated volume by the initial volume before radio frequency. The objective that Professor Sim has set is to obtain an ablation ratio over 73% that will limit the risk of regrowth. So let me show you these images to make it more clear. This is a nodule at the 6 months follow-up. So at the center of the nodule, you see this hypoechoic area, which is avascular and of high stiffness. So this is the destroyed area that can't regrow, that will be eliminated in the next months and even years. And surrounding it, unfortunately, you have a wide isoechoic remaining area, which is still vascularized and which is of low stiffness. So this is the viable area, and this can in turn regrow. And the ablation ratio tells us what is the proportion between the two and compare it to what it was before the ablation. So when you study the learning curve, now not for the volume reduction ratio, but for this ablation ratio at 6 months follow-up for the same 5 consecutive groups of 30 patients, this is what you obtain. You see that the ablation ratio improves after the 30 first patients and even more until the 19th patients. And you also see that it was very heterogeneous at the beginning for the first 30 patients, and that it's much less heterogeneous by now after 120 patients. And currently, the figure is about 87% for the ablation ratio. So what we learn is that the learning curve is much slower to obtain a good ablation ratio. This is an example of a nodule before treatment. You see it is isoechoic, it is of mixed composition, mainly solid, and this is at the bottom of the screen, the 6 months follow-up. So of course it has reduced from 70 for 78%, but moreover, it has mainly become hypoechoic, and there is a very tiny remaining viable zone here near the laryngeal inferior nerve, and the ablation ratio is really satisfactory. It is 92%. This is another case where you see at the 6 months follow-up, the nodule is entirely hypoechoic, but moreover, it is avascular, even with super resolution. This is the normal thyroid gland with a super resolution, and the nodule is of high stiffness entirely. The remaining portion, the viable one, is only here. So there again, the ablation ratio is over 90%. Let's have a look at the literature. There are only 3 reports, to my knowledge, about the learning curve. This is a total of 376 patients. All the interventionalists were highly experienced in US NFNA prior to starting RFA, and the overall rate of complications was quite low. It was 1.3% during this learning phase. All publications showed that there were 3 phases. A first phase, which is called the initial learning phase, which corresponds to the first 30 cases. Then, during the 30 next cases, it is called the consolidation phase, and there is a third phase called the proficiency phase until 90 procedures to optimize the ablation ratio. So now the question is, what exactly does we do to improve ourselves during this learning curve? What did we learn from this learning curve? So what can we teach to others to make it more quick, the learning curve? So first of all, we have to study the efficacy variables, and one of them is certainly the initial volume. Here we have subdivided the nodules into 2 groups, a group below 30 milliliters and a group above 30 milliliters. And you can see that for the 3 indicators, technical success, which means a VRR above 50%, the volume reduction ratio, the ablation ratio, the figures are much higher in the small group than in the high volume group. So the advice during the learning curve is to begin by small nodules below 30 milliliters. That can be shown nicely on these two graphs. On the horizontal axis, you have the initial volume in milliliters. And on the vertical axis here, you have a volume reduction ratio. And here on the right graph, the ablation ratio. And you see that in both cases, there is a negative correlation between these and the initial volume in milliliter. And moreover, an ablation ratio of 100% was obtained only in nodules below 32 milliliters. We have studied with Murillo D'Andrea and Pierpaolo Trimboli what should be done to obtain systematically a treatment efficacy, that is to say a volume reduction ratio above 50%. And what we have found is that if you deliver at least 2,600 joules per milliliter, all nodules will be treated with technical success. This can be studied more precisely with these two graphs. On the horizontal axis, you have the energy delivered in joules per milliliter. On the left graph, you have the volume reduction ratio on the vertical axis. And you see that there is a slight positive correlation between the two. That means that increasing the energy delivered in joules per milliliter will only slightly improve the volume reduction ratio. But on the contrary, this positive correlation is much steeper for the ablation ratio. So to obtain a good ablation ratio, you should deliver at least 1,200 joules per milliliter and maybe stick in that area around 3,000 joules per milliliter. There is a special case, that is the one of highly vascularized nodules on super resolution like this one. And for this kind of nodule, we even advise to raise the delivered energy up to 4,000 joules per milliliter, or to increase the power to 40, 50, 60 watts, if of course feasible, without risks and without hurting the patients, because of course of a heat sink effect. Now, delivering a high energy is not enough to obtain a high ablation ratio. We have to treat the marginal and deep nodular areas. Why is that so? Because what we have learned from super resolution Doppler is that the vascularity of a thyroid nodule is of a spoke wheel distribution like the one you can see on the left of this slide. Therefore, to destroy the vascular distribution, we have to destroy the peripheral areas and to put our needle tip at the peripheral zone here of the nodule and at its deep portion, taking, of course, great care of the danger zone here. Of course, this is feasible because Professor Beck has all taught us the moving shot technique, which allows us to treat successively all the areas of a nodule. And this is, of course, opposed to the fixed technique that we use for liver. Another indicator at the end of a session, besides, of course, obtaining total absence of vascularity with Doppler, is to look at the marginal zone of a nodule here. And at the end of a treatment, this marginal zone is supposed to have turned entirely hypoechoic, like you can nicely see on this example, compared to the aspect before RFA treatment, where it was isoechoic. This is an example of a complete treatment using these techniques of a 31 milliliter nodule in a single session. You see the nodule at the upper part of the slide before the treatment, the day of a treatment, and at the bottom part of the slide at 6 months follow-up. You see it has turned entirely hypoechoic with no vascularity at all and entirely of high stiffness. So that is to say that we should use a multi-parametric study to assess this destruction. Now let us come to complications. These are the ones we observed at La Pitié-Salpêtrière Hospital during the 177 first procedures. They were graded according to what published Giovanni Mauri in 2019, and we had 0.5% of severe complications. This was an infection necessitating hospitalization and IV antibiotics. 5.6 minor complications, including transient voice changes, 2 nodular ruptures, 2 vasovagal reaction, of course, some small volume hematomas, but there is in total a small number of complications during the learning curve. This was close to the figures that were published by Professor Beck and Professor Valcalvi previously. To prevent these complications, we advise to use for small nodules under 30 millimeters, a 7 millimeter active tip, not the 10 millimeter one, and especially if nodule is entirely at the isthmus. We advise to start at 30 watts and to increase it if needed and possible according to risk and pain. This is an example of a metastatic lymph node I treated. It was against the internal jugular vein. So I first performed hydrodissection to remove it from the vein. And then I used a 5 millimeter long active tip. And this in turn did no damage to the internal jugular vein. To prevent laryngeal inferior nerve damage or to cure it, we really use hydrodissection with refrigerated G5 solution. This is the nodule before the hydrodissection, and you see that by injecting the G5 here, the laryngeal nerve bathes into the refrigerated solution so it can be prevented from damages or cured from it. So these are my conclusions. Learning curve for thyroid RFA is demonstrated by all these works. It is short for improving volume reduction and symptoms. It is longer for increasing ablation ratio. So we advise to start with a previous long experience in thyroid US and FNA procedures and with relatively small nodules. During this learning curve, we learn to increase the energy and distribute it more evenly in the nodule, especially to the peripheral zone. And in this learning curve, hopefully the complication rate remains low. Thank you for your attention.
Thank you very much, Professor Roos. Very, very interesting topic. And I would like also to thank all the participants. We have 831 participants now, and there are greetings from all over the world. Also, Adrienne from Paris, that is supporting, like in a football match, Professor Gilles Roos. So thank you, Adrienne. And I think you should remember that you can use the Q&A button for your questions. I think there is a question from Professor Valcavi. Please, Professor Valcavi, go ahead. Question to Professor Roos.
Basically, it's an observation that before learning thyroid interventional, everybody should learn clinical thyroidology. Second, neck ultrasound. Third, how to perform fine needle and core needle aspiration biopsy, which was already said by in the conclusion slide by Professor Roos. So we agree on the path that all learners should have. I would like to underline that the basic is clinical thyroidology.
Any comment, Professor Roos?
Oh, I can only but agree with Professor Valcalvi. The more you will understand thyroid pathology, thyroid nodules, what are the outcomes, what are the issues, and the better you will perform the RFA, the better will be your indications. So I totally agree with this. So Thyroid US is nothing without clinics. So clinics is the base. So I totally agree with that. I support this idea.
Thank you, Professor Roos. There is time for one more question from Germany. Dr. Alina Duff asks, can you explain the medial hydrodissection to prevent the injury of the inferior laryngeal nerve? One minute for your answer, please.
Sure. So thank you for this question. This is very important and very useful. So there are two ways of performing it. Sometimes when you fear that you may cause damage because of the location of a nodule, or maybe because you're treating someone who is a professional with his voice, like a singer, you will perform the hydrodissection before starting the RFA. And sometimes it is because during your RFA session, you hear the patient cough, or you hear his voice or her voice is turning not so good as it was before. So the way you perform it, you have to have prepared previously your G5 refrigerated solution, which is in the fridge. And this has to be near your room. And then you just put it in a syringe. You stick the needle at the just close to the trachea, and then you follow your needle until it is at the really between the thyroid and the trachea, and you start injecting the G5. You see it diffuse it, and it has to diffuse between the gland and the trachea, and it makes a hypoechoic area. When you obtain this, you're successful, and you can hear the voice even in a few seconds or minutes. That goes well, and that is cured. So it's very satisfactory, but not that easy to perform.
Thank you very much, Professor Roos. I think there are less secrets for us now. And now I should move to the next speaker. As Professor Roos already said during his presentation, now I would like, it's time to have the father of the technique, Professor Jung Van Beck. Is professor at the Department of Radiology and Research Institute of Radiology, University of Ulsan College of Medicine in the Asan Medical Center, Seoul, Korea. He has been president, is the past president of the Korean Society of Thyroid Radiology, elected Austin Chair in the Asian Conference on Tumor Ablation. His main area of interest are the image-guided ablation with RFA and also ethanol of thyroid and neck tumors. He is member of all the most important radiologic society of Korea and the world, vice president of the Korean Society of Thyroid Radiology, committee member of the Frontiers in the Clinical Management of Thyroid Disease, member of the Scientific Committee of Asia Pacific Association of Image-Guided Therapy in Oncology, organizing committee member as chair of the Asian Federation of Societies of Ultrasound in Medicine and Biology and Korean Society for Ultrasound in Medicine. And he published more than 300 scientific papers on this topic. Please, Professor Beck, the floor is yours.
Thank you, Chairperson. Today, I'd like to talk about thyroid RF ablation, focusing on patient selection and techniques. This is my COI. First, I will introduce how to choose best treatment modality according to the amount of solid portion, and then introduce standard and advanced techniques. As we know, ethanol ablation has been used in cystic thyroid nodule, but it shows limitations in treating solid nodule because of uneven distribution of injected ethanol inside the solid portion. Therefore, multiple treatment sessions are necessary. So in 2008, I had a question, which is better, ethanol or radiofrequency ablation? To answer this question, we divided the thyroid nodule into 3 categories according to the amount of solid portion: cystic, predominantly cystic, and solid. And then we performed a randomized trial comparing 2 modalities. Here, this randomized trial was a single institution, a single session, non-inferiority study. Primary outcome was volume reduction ratio at 6 months follow. The result shows, the primary endpoint shows ethanol ablation achieved better than radiofrequency ablation. So we concluded ethanol is not only non-inferior but also superior, even superior to RF ablation. Therefore, it could be a first-line treatment for cystic thyroid nodules. What about P-cystic nodule? Cystic component between solid component between 10 to 50%. We also performed the randomized trial comparing 2 modalities. The result shows radiofrequency ablation achieved a better result than ethanol, but there was no statistical difference. So we concluded RFA is not superior to ethanol. Therefore, ethanol could be a first-line treatment in P-cystic thyroid nodules. However, this retrospective study and this following prospective study showed a patient with unsatisfactory results after ethanol ablation. Unsatisfactory patients were around 30%, and this unsatisfactory patient increased when the solid component increased 10 to 50%. These patients were well managed by radiofrequency ablation. Here is an example. You can see the P-cystic thyroid nodule. You can see some vascularity as solid component. After aspiration of internal blood, we injected ethanol. Here is 1 month follow-up ultrasound image. You can see the disappeared cystic component, but remained the solid portion and vascularity. So we performed additional RF ablation for this nodule. This is 8 months after radiofrequency ablation. You can see the considerably decreased its size and completely disappeared internal vascularity. So we recommend ethanol and the radiofrequency combination therapy for P-cystic thyroid nodule. What about the solid thyroid nodule? How to manage it? Here is a special report comparing 2 modalities. As you can see, in solid component, radiofrequency achieved much better result than ethanol ablation. Therefore, most of the guidelines suggest thermal ablation than chemical ablation such as ethanol. Therefore, we compared the 2 thermal ablation modalities, radiofrequency and laser. We used pooling and Bayesian network meta-analysis. In this meta-analysis, we invited all prospective studies and the pooled volume reduction was like this. Which is better? As you can see, the radio frequency achieved much better result than laser ablation in pooling method. And then we performed Bayesian network meta-analysis. In this meta-analysis, as you can see, the number one treatment modality was 2 sessions, 2 times of RF ablation is number one. Probable best was 53%, and then followed by single session RF ablation, followed by 3 sessions of laser ablation. So our conclusion was the best treatment modality was ethanol for cystic thyroid nodule. Ethanol followed by radiofrequency combination therapy for P cystic thyroid nodule and radiofrequency ablation for solid thyroid nodule. Let's move on to the techniques. Here is our guideline. Our guideline suggests 3 standard techniques. For pain control, we recommend perithyroidal lidocaine injection and RF ablation technique, transseismic approach, and moving shot technique. Let me show video file. Here is right thyroid nodule. You can see the electrode approach from medial to laterally through isthmic area. We call the transismic approach method, and then ablate the tumor by moving shot technique. We ablate the posterior portion first and then move anteriorly like this. This is called moving shot technique. We finish the RF ablation when the entire nodule changes to echogenically. That means we cover the entire thyroid nodule, but medial portion is untreated. We call the danger triangle. Here is recurrent laryngeal nerve. As time goes, 1 month later, you can see the size reduction of the tumor, and we can treat this area safely. This is the transseismic approach and moving shot technique. You can see the thyroid dedicated straight type internally cooled electrode. This electrode is short for easy control and thin to minimize normal thyroid injury. And we have various size of active tips. This table shows active tip size and the indicated condition and suggested RF power. For example, I prefer 7mm active tip in case of less than 3 cm thyroid nodule, and I use 20 to 40 watt of RF power. This small electrode, about 4mm, I prefer to use this electrode for recurrent thyroid cancer or small parathyroid lesion or PTMC. I started 5 watt of RF power and sometimes increased to 10 watt. So please remember this table. This picture shows simultaneous insertion of electrode and lidocaine injection needle. This is a typical feature of parathyroidal lidocaine injection to control pain. Here you can see the needle inject lidocaine at parathyroidal soft tissue. We call the thyroid capsule. You can see, and then I start ablation of thyroid nodule like this. This table shows the long-term follow-up result of RF ablation. The papers, the studies shows one major problem of RF ablation at long-term follow-up, that is regrowth of untreated nodule margin. That means here is a thyroid nodule. Many doctors treat the center of the nodule and under treatment of nodule margin. This is a major cause of regrowth of thyroid nodule at long-term follow-up duration. Let me show this representative case. This case shows marginal regrowth. This regrowth is common in large and vascular thyroid nodule like this. Here you can see the more than 5 centimeter vascular thyroid nodule. After first RF ablation, this is 1 month follow-up. As you can see, there's some vascularity at the margin of thyroid nodule. But what about the 3 months follow-up? You can see the regrowing and the increased vascularity of the nodule. So I applied the second ablation. After second ablation, most of thyroid nodules were treated, but we can see some vascularity at the margin of nodule. Here is ultrasound feature of 6 months. You can see the rapid regrowth of untreated nodule margin. So at third RF ablation, I treated the nodule and surrounding vessels as much as possible. So this is more than 100 months follow-up. You can see the completely destroyed and reduced nodule size. Volume reduction was about 100%. So after experience of this case, we suggested a vascular ablation technique. This technique is divided into 2 parts: artery first ablation and marginal venous ablation. You can see some marginal veins, and I treated the marginal vein as much as possible. So you can see that this is 1 month follow-up, and after second ablation, you can see the 2-year follow-up shows complete ablation of nodule. So let me finally introduce 4 types of hydrodissection techniques. Hydrodissection is very important to minimize complication. You can see the injected fluid, and this technique could minimize pain during the ablation. This is an anterolateral approach of a hydrodissection technique. Here is posterior approach technique to treat parathyroid adenoma, and here is ischemic PTMC. I used pretracheal hydrodissection technique, and to treat this nodule adjacent to trachea and esophagus, I used the danger triangle approach hydrodissection technique. So in summary, I introduced how to select best treatment modality according to the amount of solid portion. In cystic nodules, we recommend ethanol and the ethanol RF ablation combination technique for P-cystic nodule and the RF ablation for solid thyroid nodule. And then I introduced the standard RF ablation techniques and advanced techniques. I would like to stress venous staining and hydrodissection technique. And this is our thyroid team in Assam Medical Center and the RF ablation team. Thank you for your attention.
Thank you very much, Professor Beck. Outstanding presentation. We got a lot of questions. I would like to remember that you should put your questions in the Q&A section. Do not use the chat, please. Anyway, there are all the questions will be answered at the end of the webinar. I got one interesting question by Dr. Giannitto. She would like to know from Professor Beck and Professor Gill if she said that you evaluate treatment efficacy with volume reduction and vascularization with ultrasound. So do you have some experience with quantitative imaging as DVI MRI or perfusion MRI with surface neck coil? Please, Professor Beck, and if you like, also Professor Gill, Rus, give an answer.
Thank you. Very interesting question. Unfortunately, I have no experience with MRI. I always use color Doppler or microvascular flow imaging.
Okay, great. Professor Rus, do you want to add something?
No, same for me. Thank you, but
okay.
no.
Is there any comment to the presentation from the panel? Do you have any comment? Roberto?
Yes, I have a comment. Thank you, Professor Beck, for your presentation. You make clear that complete ablation is the mainstay for ablative techniques. I have an observation. To complete the ablation after 1 month implies 2 procedures. This is not welcome by most patients. They prefer 1 procedure only. Furthermore, the cost of RFA procedure increases as RFA device is disposable. A good laryngeal nerve hydrodissection may prevent nerve damage, thus permitting to perform 1 procedure only. What is your opinion?
Thank you. Very good comment, Professor Varkabi. In case of small nodule, I mean around 3 centimeter or some 4 centimeter nodules, 1 session is enough. But in case of large nodules, more than 3 or 4 centimeter, usually need at least 2 sessions of RF ablation. Maybe STARmed can reduce the cost of disposable electrode in the future.
Okay. Thank you again, Professor Beck. Thank you very much. I would like also to thank again the 831 participants. I'm sorry to not answer now, but all the questions will be answered the next. Now I would like to move to Professor Jules Ajmal. And Dr. Ajmal is an American endocrinologist. He performs his medical practice in Salt Lake City, Utah, and is completely focused on the management of thyroid and parathyroid disorders. He's expert in performing RFA, which he first brought to Salt Lake City in 2018. Since that time, he has performed more than 200 cases and has published his work in the Journal of Endocrine Society. His most recent paper on thermal ablation is the first to be published in the United States by an endocrinologist. He created the North American Society of Interventional Endocrinologists and currently serves as its first president. Now, I'm very proud to introduce him and to ask him to present the presentation with name Autonomously Functioning Thyroid Nodule RFA. Please, Professor Ajamal.
I would like to welcome everyone, and I would like to thank Dr. Mercante for the nice introduction. My name is Jules Aljamal. I'm the current president of the North American Society of Interventional Endocrinologists, and I'm here today to share our experience using treatment with radiofrequency ablation for treating toxic adenomas. I would like also to thank our team in the thyroid clinic, Salt Lake City, Utah. And also I would like to thank Dr. Roberto Falcavi for his invitation, allowing me to share our experience with you all. I have no conflict of interest relevant to this presentation. My goals today is to touch briefly on the prevalence and the natural history of toxic adenomas, discuss the current guidelines considering treatment with radiofrequency ablation of toxic adenomas, review the most recent meta-analysis looking at efficacy of radiofrequency ablation in toxic adenomas, and last, present our institute outcome over the last 3 years. What would I not be talking about today is comparison of radiofrequency ablation with other ablation technique, or comparing radiofrequency ablation with current standard of cares, including surgery and radioactive iodine. On physical exam, thyroid nodules are palpable in 6% of women and 1.5% of men. Around 10% of all thyroid nodules are toxic adenomas. The prevalence of thyroid nodule increased with using imaging study, and it's estimated to be around 20 to 80%. This prevalence increased with aging. Also, from a non-toxic, autonomously functioning thyroid nodule, around 10 to 20% will become toxic in 1 to 6 years. Hyperthyroidism prevalence is around 1.5% estimated in the United States. 10% of all patients who have hyperthyroidism have a toxic adenoma. The ratio of female to male is 5 to 1 of toxic adenomas, and the prevalence of toxic adenomas is higher in iodine deficient countries, and also the increase was Asian. When we look at the guidelines, most of the guidelines recommend considering thermal ablation technique or RFA for treatment of toxic nodules or pre-toxic nodule with a volume less than 10 to 15 cc's. Some recommend against RFA treatment for larger thyroid nodule versus others recommend careful planning for those large nodules. When we look at the efficacy of RFA in the most recent meta-analysis by Muhammad and his colleague, what we can note is that their conclusion in their meta-analysis that normalization was achieved in around 62% of 62%. That meta-analysis included 10 studies. What I would like to point out here that after the year 2012, most of the studies used a moving shot technique as the standard of treatment using RFA and ablating thyroid nodules. And with that improvement in the technique of ablation, we can notice that in the most recent study, there was a significant improvement in achieving normal thyroid function testing. Also, what I would like to point out that in the most recent study compared to older study, which had a fixed technique, the most recent study, initial volume of the thyroid nodule was in most of those studies less than 15 cc. Last, I would like to point that number of patients in each of those studies was around 20 to 25 patients. In conclusion, achieving full ablation of the entire thyroid nodule is essential to improve the success rate in achieving normal thyroid function test, and that's the role of moving shot technique. And the smaller the thyroid nodule, the higher the success rate. Now, what about our data? Between November 2018 and December 2021, we performed more than 200 RFA procedures. We treated 49 autonomously functioning thyroid nodule in 41 patients. 6 of those patients were lost to follow-up. Those patients had a single thyroid nodule. 1 patient in our group had bilateral toxic nodule treated on 2 different sessions, and 7 patients had 2 toxic nodules on the same side that were treated at the same session. What I would like to share also, that majority of those patients who were interested in radiofrequency ablation were patients who wanted to avoid surgical scar, hospital stay, or the long-term complication related to the standard of care, including hypothyroidism. In our group, majority of those patients were female, 39 to 2 males. Median age was 46, ranging between 25 to 78-year-old. Majority of those nodule on imaging study were solid or dominantly solid, and few of those nodules were spongiform. Almost half of those patients were on treatment with methimazole, and in the group that were lost to follow-up, 2 were on treatment with methimazole and 4 were not. When we looked at the volume change percentage over time in response to treatment with RFA, and in all those graphs, I would like to point that the line inside the box represents the median, and the mean is represented by the X. We can see that the mean volume reduction improved gradually with time in all our patients who are treated. And when we look at that volume reduction with multiple points over time, we can see that majority of volume reduction happened in the first 6 weeks to 3 months. And in the patient that we had a long follow-up for, majority of those patients, the volumes stay stable over time up to 2 years and a half. When we also look specifically at the initial size of the nodule and its impact on the volume response to treatment with RFA, we can note that at 6 weeks, most of the nodule achieved a mean volume reduction of 50 to 60%, regardless of the size. And when we look at those nodules at 6 months, we can see that nodule that had a volume less than 10 cc continued to decrease in size compared to nodule who had a volume larger than that. I would caution here that this conclusion is based on a small sample. If we divide our group of patients into patients who were not on treatment with methimazole versus patients who were, in the group that were not on treatment, we had 4 patients who were lost to follow-up. We had follow-up for 17 patients, 12 had a single toxic nodule, and 5 had toxic multinodule coitum. Of the 12 patients who had a single toxic thyroid nodule, 10 patients had a normal thyroid function test, which is equal 83% after treatment with RFA. All of those patients who achieved normal thyroid function test had a thyroid nodule volume before treatment less than 14 cc. When we look at TSH change after treatment, we can see that TSH significantly improved after 1 session of RFA in those patients, and also free T4 level has significantly improved. I would like to point out here that in the 2 patients that did not achieve normal TSH level, 1 patient had a thyroid nodule volume more than 50 cc, which had dropped closer to 60% after RFA, and his free T4 level was significantly above normal and then became normal after the first treatment. As for the second patient, the free T4 level significantly dropped after the first treatment, and TSH level continued to be suppressed. We have only 1 follow-up for that patient 6 weeks after the procedure, and I'm expecting the thyroid function test will normalize on the future follow-ups. When we look at the response to one treatment with RFA over time in this group of patients who were not on treatment with methimazole, what I would like to point out here that TSH level improved and continue to improve gradually over time. Again, I would like to point out here the sample is small for patients who are followed more than 1 to 2 years. In this group, we had 5 patients who had toxic multinodule goiter. Those patients treated 2 nodules toxic on the same side with RFA. The average volume of the thyroid nodule was around 4.7 cc, with a volume ranging between 1 to 15 cc. Volume reduction was around 55%, ranging between 46 to 87%. 60% of those patients, 3 of 5, achieved normal thyroid function test. Now, in the group of patients who were on treatment with methimazole, 2 patients were lost to follow-up, 11 patients discontinued treatment. 8 of those patients achieved normal thyroid function test. All patients who achieved normal thyroid function test have a initial thyroid nodule volume less than 11 cc. In the last 3 patients, 1 of those 11 patients needed repeat treatment after the first RFA because of persistent TSH level being suppressed. After the second treatment, the patient TSH level normalized. This patient had initial thyroid nodule volume more than or closer to 20 cc. In the other 2 patients, we do not have any follow-up yet after the RFA treatment and stopping the methimazole as their follow-up was recent. 1 patient in this group needed repeat treatment 581 days post-RFA due to volume increase more than 50% with decrease of TSH level and recurring of symptoms. When we look at TSH level change before treatment with tapazole and before RFA, and look at TSH level after treatment with RFA and stopping treatment with methimazole, we notice in this group there was a significant improvement in TSH level. 7 patients who did not discontinue treatment had a nodule volume more than 15 cc. In those patients, 5 dose of methimazole was reduced and 2 patients did not change their dose. So how a typical RFA treatment for a toxic nodule is done? First, we do a subcapsular injection of lidocaine. This is followed by a vascular mapping. After that, we proceed with transismic approach. This is followed by moving shock technique ablation. And we continue in this process and repeat it until complete absence of the vascular flow. Here's an example of a typical RFA treatment. This is a patient who had a toxic nodule with TSH level 0.02 symptomatic. The volume was around 5 cc. At 6 weeks, she had a 67% volume reduction after RFA, and the patient became subclinical hypothyroid. She was treated with levothyroxine for a period of 6 to 8 weeks and then discontinued. 6 months post-RFA, she had a volume reduction of 85%, and her TSH level of any treatment was 2.69, and the patient was asymptomatic. In our data up till now, we do not have any major complication, especially in those patients who had toxic adenomas. 1 patient, as I mentioned, progressed into temporary hypothyroidism that resolved after 4 months of the treatment with radiofrequency ablation. In conclusion, RFA should be considered as a first-line treatment for single toxic adenoma with a volume less than 10 to 14 cc's. 83% of patients who have a single toxic adenoma who are not on treatment with methimazole in our sample achieved normal thyroid function test, and this was maintained up to 2 years. Again, sample is small. 60% of toxic multinodule goiter achieved normal thyroid function test. In the patient group who were on treatment with methimazole, 61% of those patients discontinued treatment, and 44% achieved normal thyroid function test without any additional treatment up till this point of time. 10% achieved normal thyroid function test after 2 sessions of RFA. 5%, which represent 1 patient, had failed treatment after 2 years and required repeat treatment. And we're still waiting to see the outcome in the next few months. Last, I would like to emphasize that moving shot technique, full ablation of the thyroid nodule, and margin treatment are essential to achieve higher success rate and to prevent regrowth and failure of treatment over time. I would like to thank my family. Without their support, none of this would have been achieved. And I'm open for any question. Thank you.
Thank you very much, Professor Ajmahal. A very clear presentation. We had a lot of questions. I'm sure you will answer to every single participant at the end of this webinar. I would like just to take one of those questions. What about microwave ablation of thyroid nodules? Have you got any experience, and what do you prefer, RFA or microwaves, and why?
So I did not have the experience about microwave ablation, but I can point out with RFA, it allows the capability to ablate all of the thyroid nodule with a moving shot technique. I would refer to a Professor Valkavi who had maybe more experience in this technique, or anyone else who had the experience of using microwave. Microwave is not available in the United States. I think recently one company received FDA approval, and they are most likely going to become part of the treatment choices in the future.
Thank you very much. Thank you. We should be on time, so we should move to the next speaker. Thank you again, Professor Ajmahal, for your very, very interesting presentation. Let's move to Professor Erivelto Volpi, who's going to present the lecture, Thyroid Micropapillary Tumor, RFA. Professor Erivelto Volpi is a head and neck surgeon in Brazil. He works at Osvaldo Cruz German Hospital in São Paulo and is a professor in charge of the thyroid nodules RFA therapy course at Citrus Medical Center in São Paulo. His main areas of research are thyroid cancer, thyroid and parathyroid surgery, and minimal invasive procedures. Dr. Volpi was one of the first to introduce radiofrequency ablation to treat thyroid nodules in Brazil and trained many physicians from Brazil and abroad in this technology. He's an associate editor of Clinical Thyroidology and review editor of Frontiers in Endocrinology. Dr. Volpi is currently a member of the Surgical Affairs Committee of the Latin American Thyroid Society and the Research Committee of the American Thyroid Association. Please, Dr. Volpi, the floor is yours.
Hello?
Yes, we can hear you. Go ahead.
Okay, let's go. Wish to thank you to my very good friend, Dr. Valkavi, for the kind invitation and the STARmed. It's a great pleasure to be here. It's actually an honor to be here. My name is Erivelto Volpi. I have nothing to disclose. There is no conflict of interest for this presentation. Before I start my presentation, I have to do some special thanks to Dr. Gregory Randolph, Dr. Beck, and Dr. Valkavi that I meet for the first time in the first TNT meeting in Reggio Emilia, November 2019. And Roberto, we didn't have a photo together. I hope we can, this year, we can meet in person and take a picture together, Roberto, okay? Well, this is my team in Brazil. Together we have treated almost 1,000 nodules and more than 800 patients by RFA for malignant and benign lesions since 2018, when we started to do this procedure in Brazil. We are very proud that we took part in this team with many international societies that wrote the guidelines related to RFA in the treatment of thyroid nodules. We are very proud to be part of this team. Well, we know that papillary thyroid cancer is the most common thyroid cancer, representing more than 70% of all thyroid malignancies. We know also that we classify low-risk papillary thyroid cancer as small tumors inside the thyroid gland with no capsular invasion or extrathyroidal extension, as well without lymph node or distant mets. We know that papillary thyroid microcarcinoma is a thyroid cancer measuring less than 1 centimeter, and it's considered a very low risk disease with the mortality less than 1%. Of course, I'm a surgeon, and we know that surgery is the first line treatment option. We have in the last few years progressed in surgery modalities from conventional surgeries to robotic or endoscopic surgeries. So we know that even though with all these surgical modalities and with all the technologies that we have, complications even in a very low rate can occur, especially recurrent laryngeal nerve damage and hypoparathyroidism. All these tumors we know are a favorable prognosis, and the current guidelines support less extensive approaches like allopectomy instead of total thyroidectomy. However, post-surgical hypothyroidism can occur, and it's important to say that's one of the biggest complaints of patients of surgery. We know that many patients don't want to take hormones forever or have difficulties to deal with the use of it. By other side, we have active surveillance that has recently adopted as an option for low risk papillary microcarcinoma. The American Thyroid Association suggests that could be a very good and perhaps a first-line option for the management of low-risk papillary thyroid cancer. Even though this approach has promising results, one third of the patients are not comfortable with the presence of the cancer inside the neck, and many patients give up of active surveillance. A recent review shows that patient anxiety was the main reason for stopping active surveillance. So why minimally invasive treatments? One, because more and more patients are concerned about their quality of life. The easy access to information. We know that Dr. Google is reached 1 million times every day, and encourage the patients to seek less aggressive treatments. And new technologies are available to safely ablate thyroid nodules without removal the gland itself, and preserves the thyroid function. This way, we can think about a path between active surveillance and surgery. That could be the thermal ablation of thyroid nodules. Here in the top picture, you can see a micropapillary thyroid cancer. In the center picture, the RFA electrode inside the nodule, and the bottom, the treated area immediately after RFA, that this area is bigger than the nodule. So let's see how the RFA works from micropapillary thyroid cancer. We have this research from Cho showing that when we treat micropapillary thyroid cancer, just the treatment area of the nodule grows, because when we treat cancer, as shown before, we need to treat not only the nodule itself, but an area surrounding the tumor as a safety margin. And you can see in the first 6 months, seems that the nodule in the ultrasound grows. But after the first 6 months, usually, as you can see in the red arrow, the area treated starts to shrink. And after 1 year, the average of reduction of the tumor is 50% after 1 year. And as you can see in the blue square, after 2 years, the tumor virtually disappear. It's a very interesting option for treat micropapillary thyroid cancer. Here I can show one case of our group. In this, on top left, you can see on the red square, the micropapillary thyroid cancer, and just the image after the radio frequency. You can see the bigger area surrounding the tumor itself. Then after 1 month, the tumor, there is no change in the size of treated area, but after 3 months, in this case, it's a very favorable case, the tumor started to vanish. And after 9 months, as you can see in the green square, the complete disappearance of the tumor. Well, when you compare radio frequency ablation versus surgery, it's a very interesting paper from Jung. You can see here the efficacy of RFA in selected patients. It's the same in terms of efficacy after 5 years when you compare this group of patients with surgery, even though lobectomy or a total thyroidectomy. And when you compare with adverse effects, the results are from RFA. The adverse effects, you have less adverse effects when you compare RFA with conventional surgeries. So this work conclude that for carefully selected micropapillary thyroid cancers, RFA has the same outcomes after 5 years of follow-up. The complication and costs were lower, and the most important, the quality of life was better. Of course, longer follow-ups and additional studies in our group started to do these studies will be necessary to demonstrate if these findings are durable and producible. This is a very interesting review showing that the reduction, a meta-analysis showing that the median reduction of the volume of the nodule after 1 year is 98%. Is a very good number. And the complete disappearance of the nodule, it's almost 60% of the patients. And this meta-analysis show also that the recurrence index is very, very low, about 0.5% of the studies. When we talk about complications, all major complications are related to voice change. This systematic review showed there are 11 major complications, of which only one was a permanent vocal fold palsy. We have 23 minor complications that included pain, alteration of hormone levels, and hematomas. And this meta-analysis show immediate hoarseness that solved in up to 1 week. So the major complication rate was 1.5%, and the minor complication was 3.2%. I was to share with you my own experience with over 300 nodules. Of course, it's not only for malignant nodules, it's for benign and malignant, but in our experience, pain was the most important complication. Ecchymosis, as you can see, it's very common. In my opinion, it's not a complication, it's a consequence. Skin allergy, cough, dysphagia, hoarseness, and I had one case of vocal fold palsy and 2 cases of Claude-Bernard-Horner syndrome. It happened at the beginning of my learning curve. As you can see here, a patient in the first day of RFA, it's a multinodular goiter, a huge multinodular goiter. You can see the ecchymosis and the multiple punctions. And after 35 days, it's remarkable the difference in the size of the neck. This is regarding the quality of life. That is one of the most important conditions when we treat thyroid cancer, is the quality in patients treated by RFA. There are some significant differences, especially in the physical, broad physical pain, emotional well-being, and physical components. It's remarkable the differences. The study shows that RFA is very superior when you treat patients with micropapillary thyroid cancers. Well, another option regarding the usefulness of radiofrequency is to treat metastatic lymph nodes in selected patients. As you can see, we are treating a single nodule metastasis. And I want to show a recent case that we have here in our clinic, a patient with the second recurrence with only one lymph node metastasis. And you can see the metastasis, the jugular and carotid artery, and here you can see the electrode inside the metastasis. Well, I wish to wrap up my presentation with the take-home messages. We know the RFA is changing the way we see the nodule, the thyroid nodules. We should treat the whole patient, not only the nodule. RFA represents a new treatment tool. We should master the technique. Even we are clinicians, endocrinologists, ENTs, surgeons, radiologists. RFA doesn't compete with surgery, but is an additional option and should be considered a reasonable option for selected. Its most important point is the correct selection of the patient with micropapillary thyroid cancer. The major concern of the patient is not the surgery itself, but the quality of life after the procedure and the need for medication forever. RFA can help avoid both. That's it. I wish to thank you for the opportunity, and thank you very much.
Thank you very much, Professor Volpi. I think nobody is sleeping now because your presentation was so interesting. I think we are on time. We got time for 2 questions. There is one from Dr. Suakalel. We would like to know what's the systematic pre-RFA whole body assessment, such as CT scan, scintigraphy, or so on, to eliminate lymph node and distant metastasis.
Well, we use just ultrasound. Ultrasound is a powerful tool when you use it, and usually we do 2 ultrasounds. We have our radiologist, and we perform also in our office. We perform a pre-ablative ultrasound to evaluate the presence of lymph nodes.
Great. So there is no whole body assessment. A second very brief question is, you reported low percentage of recurrence. How do you follow up your patients? I mean, what kind of imaging do you use and how often? Is ultrasound sufficient, or do you use something to check if there are distant metastases?
Well, before we think about this, we need to reinforce the importance of the selection of the patient. Of course, if you have a good patient selection, the chance of have distant mets or even lymph node mets is very, very low. This way, we use just ultrasound to follow up our patients. We do not use any full body scan, and we just follow up the patient with hormone levels and ultrasound.
Thank you very much. Again, I would like to thank all the participants, more than 800 connected, and there are a lot of questions we will answer at the end of the webinar. Now, I'd like to move.
May I ask one?
Next,
A very short one. Do you check thyroglobulin levels, Roberto?
Yes, but in off-label way, Roberto. I use because it's a new avenue of research, so we do not have any background to use it, but we just start as a parameter in our case. We start to do our statistical collect. We are in phase of collecting data, and we are using a thyroglobulin and antibodies also. I just want to point out one important thing. In some patients, the TSG, the TSH levels in some patients used to increase after the procedure. I don't know the experience of Dr. Beck and yours and of the other colleagues of the panel, but in some patients, the TSH started to increase just after the procedure, and then from 2 to 3 months, it started to decrease. It's interesting.
Okay, thank you very much for this comment. Now, I would like to move to the next speaker. Dr. Roberto Novizio will present the side effect of the thyroid RFA. Dr. Novizio is assistant at the Endocrine and Thyroid Clinic of Reggio Emilia. He is resident physician in endocrinology at Catholic University of the Sacred Heart of Rome, and is also General Secretary of the TNT Association. Please, Dr. Novizio.
Hello, everyone. Thanks, Chairs Dr. Valcavi and Professor Mercante for the introduction. I would also like to thank all the faculty and audience for the participation in TNT Association webinar on thyroid radiofrequency ablation. This presentation is focused on possible side effects and complications of thyroid RFA, a really interesting topic both for experienced operators, but especially for retraining interventional thyroidologists. Just to dot the I's and cross the T's, side effects are defined as negative foreseen consequences that are expected when a drug or treatment is administered, while complications are unexpected problems that arise following a procedure, treatment, or illness. According to definition of the Society of Interventional Radiology, major complications are defined as one that may threaten patient's life, lead to substantial morbidity or disability, or result in a lengthened hospital stay. All other complications are considered minor, and focusing on radiofrequency ablation of benign thyroid nodules, the overall complication rate is less than 5%, while the major complication rate is less than 2%. For practicality reasons, complications and side effects can all be sorted out in 3 categories based on the time of onset. So we can have intraoperative side effects and complication, immediate post-operative, and peri-procedural and delayed. This way of classifying enhances the signs and symptoms to focus on during different phases of treatment and follow-up, allowing for the better tailoring of countermeasures to prevent them. Possible intraoperative side effects or complications are intense pain, intranodular or pericapsular bleeding, vasovagal reaction, and intense cough. Pain is the most common complaint during procedure with an incidence rate ranging from 2% to 17.5%. Pain is generally referred at the entrance point of the needle or diffusely in the anterior part of the neck. Occasionally, pain can radiate around the neck, spreading to the gonial angle, the ear, the shoulder, or teeth. And to minimize the discomfort, local anesthesia with the lidocaine 2% is generally performed in the ambulatory setting. since sensory nerves are present in the thyroid capsule but not inside the thyroid gland, pericapsular anesthesia is sufficient. Lidocaine has a rapid action onset but a rapid dissolution, so that a subsequent infiltration will dilute bupivacaine diluted with the physiological solution can help to get a prolonged anesthetic effect. While almost all patients experience mild pain, few patients suffer from intense intraoperative pain that can require medications such as intravenous paracetamol, methylprednisolone, or even the interruption of the procedure. Pain and intense pain during procedure decrease to 0% if the procedure is performed in operating room setting under general anesthesia, but this advantage is discussed in some authors consider pain as an early detector of complications. About bleedings, the incidence of intranodular bleeding is about 7.5%, while 2.5% for pericapsular bleeding. Most of time, hemorrhages are asymptomatic and can be detected by ultrasound as a rapidly expanding hypoechoic or anechoic signal. Intranodular bleeding generally occurs during needle insertion, possibly with an enlargement of the target nodule, while pericapsular bleedings tend to be evident at the end of the procedure as a thin anechoic layer, probably due to tissue needle-related stress. Hematoma completely disappears after 1 or 2 weeks, and to prevent hematoma, stopping medication associated with the hemorrhage risk can be useful for 1 or more days based on the type of the drug before radiofrequency ablation. Immediate radiofrequency ablation after needle insertion into the nodule prevent and reduce the intranodular bleeding by vessel coagulation. Mild pressure can help in limiting the progression of pericapsular bleeding. And although there are no cases described in literature of life-threatening hemorrhages, it is necessary to evaluate during and after the procedure the progression of the hematoma, since massive form can in case cause airway obstruction requiring emergency surgery. Vasovagal reaction occurs in about 2% of procedures. Vagus nerve stimulation can trigger the activation of parasympathetic nervous system with cardiovascular symptoms such as bradycardia, hypotension, bronchospasm, vomiting, or defecation. Most of the time, symptoms are mild, lasting up to 15 minutes, and usually the recovery is spontaneous. It is important to stop the procedure until the complete recovery. This reaction is associated with a nodule nearby the vascular bundle of the neck, since the vagus nerve is usually located between the common carotid artery and the internal jugular vein, but it may also be located adjacent to the thyroid gland. Atropine administration in operating room setting could be precious for severe reaction. Intense cough has been reported in up to 5% of cases treated in ambulatory setting. It can last up to 1 minute. It does not seem to be associated with any injury to the trachea or larynx, but the simple movement of the needle into the thyroid gland seems to tickle cough reflex. So powering off and repositioning of the needle can favor a faster recovery. Immediate post-operative side effects and complications occur 24-48 hours after the procedure. So we can experience swelling, cutaneous burn, transient or permanent laryngeal dysfunction, brachial plexus injury, and Horner's syndrome. Starting from swelling, a minimal amount of transient edema surrounding thyroid parenchyma immediately after radiofrequency ablation is not evitable. Moderate swelling is quite common, and it is present in up to 10% of cases, but it cannot even be reported as a side effect unless pressure symptoms take place. Administering intravenous methylprednisolone reduce swelling rate. In our center, the protocol is administering intravenous methylprednisolone 40 milligrams in bolus during the procedure. Cutaneous burn is a damage to the skin caused by heat. A few cases of first-grain skin burn are described in literature, presented with skin redness and mild pain. Ice pack after RFA reduce burn and bruises, and also burn at pad attachment to the thighs have been described in liver RFA, but not in thyroid RFA, where the risk is lower because of the lower energy used. Laryngeal dysfunction is a major complication, scaring both for the patient and the physicians. Impairment of the recurrent laryngeal nerve due to eating entails paralysis of the all intrinsic muscle of the larynx, except for cricothyroid muscles that are innervated by the superior laryngeal nerve. Patient can experience voice changes and hoarseness that can be found during the procedure or immediately after the ablation. There are different proposed mechanisms of nerve dysfunction, including RFA-induced thermal injury of the recurrent laryngeal nerve, but also lidocaine injection narrowed by the nerve, stretching of the nerve over an hematoma, post-hemorrhage inflammation, and fibrosing around the nerve. Voice change affects about 5% of patients, and most of time it is transient with spontaneous recovery after a few months without special treatment. However, laryngoscopic evaluation can help in objectifying the vocal cord paralysis, and phoniatric re-education together with prednisone cycles may be useful in accelerating the recovery. Generally, the recurrent laryngeal nerve is located in the tracheoesophageal groove, and maintaining at least 3 millimeters of distance between the tip of the needle and the dangerous triangle helps in avoiding injuries. When treating ablation units narrowed by the nerve is necessary, hydrodissection between the nodule and the dangerous triangle is helpful in protecting the nodule. Hydrodissection consists in using dextrose 5% at 5 Celsius degrees injected in between the danger zone and the ablating area. And saline is not recommended to perform hydrodissection as it contains ions and is not electrically inert. About the brachial plexus injury and Horner syndrome, very few cases have been reported. Keeping the needle into the thyroid gland during ablation, respecting the transystemic approach and the movie shot technique minimize this risk, avoiding to launch the brachial plexus or damage the middle cervical sympathetic ganglion that is located bilaterally at inferior third of the thyroid gland, laterally to the common carotid artery, often wrongly identified as a lymph node at ultrasound examination. Eventually, periprocedural side effects and complications occur within 30 days after the procedure, while delayed complication and side effects occurs after 30 days. So we can have a fever, nodule rupture, and nodule colliquation. Starting from fever, fever can occur after thyroid RFA, but no precise cause has been identified. Over-the-counter medication are sufficient in treating the rising in temperature, not requiring any additional therapy in very most of cases. Almost all the time, the fever regresses spontaneously within 3 days after RFA, but if rising in temperature persists, of course, blood exams and imaging tests are suggested. Nodule rupture is a quite rare complication. During radiofrequency, the RF needle can disrupt the thyroid capsule and the thyroid nodule capsule, generating a leakage of the material into the neck muscle fascia. This pill does not occur immediately after the procedure, but requires 1 to 5 months to appear and give symptoms. So patients complain about a red and painful lump that arises when the content of the nodule has spread through the muscle plant to the subcutaneous tissue between the skin and the thyroid gland. Patients report sudden neck swelling and pain at RFA site with compressive and cosmetic symptom, and no specific nodule characteristics are predictive of nodule rupture. However, bigger size nodule requiring a longer ablating time with higher power can be at risk. Even if nodule rupture is often considered as a major complication, it is spontaneously in 2 to 4 months. To avoid nodule rupture, few strategies have been proposed. Knotting up the needle's entry point and maintaining a safety space of 2 millimeters from the needle's entry point are paramount. There is no established management protocol for nodule rupture, but over-the-counter anti-inflammatory and analgesic drugs may be used, and antibiotics may be used if necessary. Invasive procedures such as aspiration are not suggested, since they may increase the risk of infection or abscess formation. Colliquation or pseudocystic transformation can occur a few weeks after the procedure. Again, patient complained about pain and sudden swelling similarly to nodule rupture, however differently from nodule rupture, the colliquided material stay into the thyroid nodules, generating in case compressive or cosmetic symptoms. In our center, we use oral methylprednisolone 60 milligram per day after RFA for 15 to 25 days with a step-down approach plus lansoprazole to reduce the incidence of this complication. Ultrasound is useful for diagnosis, but normal ultrasound appearance of thyroid after radiofrequency ablation may be misleading. Also, cases of abscess formation starting from nodule rupture or colliquation are described in literature, and that case required surgical drainage. This slide helps us in summarizing our travel through the temporal onset of possible side effects and complications of thyroid RFA, and conclude that thyroid RFA is an effective, well-tolerated and safe therapeutic strategy for the treatment of thyroid nodules. Complication rate is low when performed by skilled operators, and knowledge of ultrasound-based neck anatomy and this clinical significance is essential for a safe and effective ultrasound-guided procedure. So thank you very much again for your participation in this webinar, and I take this opportunity to publicly thank my maestro, Dr. Valcavi, for all the invaluable lessons. I hope this presentation will be of use. Goodbye.
Thank you very much, Dr. Novizio. Very interesting. I got questions for all the panelists. So is there anybody that would like to add, comment, or give some tricks and tips for the participants in order to reduce or avoid complications?
So I can share our experience and our practice. Generally, what we do, we provide patient with a cold compressor they apply on the neck after the procedure. And most of our patients don't take any medication after the procedure, even with edema. That compression with cold usually help resolving those symptoms in 48 hours. We usually tell patient to avoid any major physical activity that puts strain on the muscle of the neck. And most of our patients go back to work in 48 hours without any limitation after that.
Great, thank you. Other comments? There is also one question from the yes? No, sorry. From the participants, do you perform through cut instead FNA? Is there any of you using this approach to have a diagnosis?
In endocrine and thyroid clinic, we perform both fine needle aspiration and corneal biopsy based on the type of the nodule, on the situation. But in the ATC, we can perform both FNA and corneal biopsies, and we have pathologists that are trained in reading the corneal biopsies samples.
Thank you, Dr. Novizio. There is a question you should answer, please. Do you perform RFA in an outpatient setting or in one-day surgery? So you keep the patient
Thank
sleeping.
you for the question, because we have some unpublished data about a comparative study that we have conducted about the incidence of side effects and complications in the ambulatory setting versus operating room setting. And our workflow in endocrine and thyroid clinic is to perform thyroid radiofrequency ablation in operating room setting with general anesthesia. So we use fentanyl, propofol, and midazolam that are useful to have anterograd anesthesia that is welcome from patient, but also help operators to easily perform the RFA. So in our unpublished data, we see that, for example, I see among Q&A, the incidence of nodule rupture is about, in our case, 2.5%, but is 0% in operating room setting. We have to make many considerations about it, about cost, and the fact that if the patient is sleeping, we cannot ask him to speak to check for recurrent laryngeal nerve damages or of course, patients cannot feel pain, so we do not have that check as early detector or major complication, but in our data, we are sure that performed radiofrequency ablation in the operating room setting strongly decrease the incidence of both side effects and complications.
Thank you very much. I would like to thank again participants. There are some
May
of them.
may I add just an observation, quick observation?
Please go ahead, please.
A hydrodissection is the mainstay. Basically, we didn't observe any laryngeal dysfunction since we systematically introduced hydrodissection in all patients before doing the RFA procedure.
Okay, thank you. There is one more comment from Professor Ajmal, please. You raise your hand, please.
I would like also to share that on all our patients, we do the procedure in the clinic and the office. We don't do it under general anesthesia. We do it under conscious sedation, which includes only midazolam. We always evaluate vocal cord before procedure by ultrasound. It has a sensitivity of 98% to pick up a paralyzed nerve, and we perform that at the end of the procedure. So those are small kind of tips that we recommend everyone who perform RFA to use by looking at the vocal cord before and after.
Great comment. Thank you very much, Professor Ajmal. And I will say to everyone that all your answer will be, all your questions will be answered at the end of the webinar. Now we should move on with the next speaker. Professor Gregory Randolph is a professor of otolaryngology and neck surgery, thyroid surgical oncology at Harvard Medical School in the Department of Otolaryngology and neck surgery and surgeon at Massachusetts Eye Infirmary Hospital. He has focused the bulk of his research on recurrent laryngeal nerve anatomy, preservation and monitoring during thyroid cancer surgery. He has over 250 peer-reviewed publications and over 100 chapters and reviews and books. He has published an endocrine surgical text, very famous, The Surgery of the Thyroid and Parathyroid Glands. He served as president and director of international affairs for the American Academy of Otolaryngology and Neck Surgery and covered many roles in the American Thyroid Association and the American Head and Neck Society. Currently, he is the president of the International Thyroid Oncology Group and otolaryngology governor at the ACS. Unfortunately, he cannot be present today due to a synchronous meeting, but he sent us his presentation. Please play the video. Okay, we cannot hear the sound.
Hello, this is Dr. Randolph. I'd like to welcome you to our lecture on radiofrequency guidelines that are now globally established, 2022. I want to welcome you also to the TNT Association meeting, and also give a special thanks to my good friend Roberto Valcalvi for his kind invitation to present this material. Again, I will be reviewing a recent paper, No Financial Disclosures Relevant to This Presentation. And this is the paper. It focuses on a variety of ablative technologies. It is now published in head and neck surgery. The focus of it is primarily radiofrequency ablation, but it discusses and covers a number of other ablative technologies. It is endorsed by really a global consortium of organizations under the banner of the American Head and Neck Society Endocrine Surgical Section, but is also endorsed and created by the Asia Pacific Society of Thyroid Surgery, the Association of Medical Endocrinology, the British Association of Endocrine and Thyroid Surgeons, the European Thyroid Association, the Italian Society of Endocrine Surgery Units, the Korean Society of Thyroid Radiology, and the Latin American Thyroid Society, as well as TNT, the Thyroid Nodules Therapies Association. So a real global and multidisciplinary group of individuals putting this together. The author panel is a really renowned group of surgeons, endocrinologists, and radiologists, and Roberto was certainly front and center with his organization having input in this guideline. The guideline is a group of materials looking at background of principles of thermal and laser, microwave and HIFU and alcohol ablation, but then we made recommendations, and these recommendations were vetted through the renowned author panel through a modified Delphi method. So the framework of the paper really is this grouping of topics that include both pre-procedural evaluation steps, advice regarding ablation technique, as well as post-procedural considerations in patient management, the need for adequate outcome measurement for radiofrequency to be rationally applied, to discuss some complications, and then make some best practice recommendations regarding RFA. So to start now, we have a pre-procedural evaluation, and so this covers the range of different aspects that need to be considered prior to initiating a radiofrequency program. It looks at the types of nodules that can be treated, the need for cytologic evaluation, the ability to treat certain types of malignant disease, and it talks about the necessary assessments prior to surgery, ultrasound and voice, informed consent, and general issues relating to procedural fitness and anticoagulation. Several recommendations in this pre-procedural space include that basically the ultrasound-guided ablation procedures may be used as a first-line alternative to surgery for patients with benign nodules that have compressive or cosmetic manifestations of the nodularity, and can also be utilized, recommendation 2, for autonomous and functioning nodules who have a contraindication to first-line treatment. Further, the pre-procedural spaces annotated with recommendations 3A, B, and C, which says that radiofrequency ablation can be considered for patients with papillary microcarcinoma, recurrent carcinoma, and that the management of such patients requires the biochemical and imaging assessment to determine the impact of radiofrequency when it is applied to these patients with primary small bowel. The pre-procedural assessment includes voice assessment, as it would prior to thyroid surgery, and that patients with voice impairment need laryngeal exam prior to initiation of RFA if their voice is judged to be abnormal, and that bilateral potential injury is averted with recommendation 4C, that laryngeal exam is performed prior to ablating the contralateral side after ipsilateral ablation, and that in the setting of ablation, there is a complete radiographic, biochemical, medical, and symptomatic evaluation that is performed to all patients prior to RFA, and that a thorough discussion, including expected outcomes and potential risks, should be had with patients undergoing ablation procedures. The list of evaluation requirements are listed in Table 2 for malignant disease and for benign disease. And that a uniform pre-procedural checklist is offered in the paper. You can use this then in your clinic. It can be torn out of the paper and utilized as to the necessary issues that should be managed and considered prior to initiating an ablation in a given patient. The next segment of the paper then looks at various techniques. I'm not going to go too much into the details here. We do look at techniques for each of the individual ablative technologies and look at some associated equipment requirements for laser, microwave, microwave, HIFU, alcohol, as well as radiofrequency ablation. And we make some general recommendations as to the degree of monitoring that is required for patients undergoing radiofrequency. And then we make some recommendations regarding also techniques relating to hydrodissection, which is a process by which target lesions can be safely ablated in the setting of adjacent vital structures, and basically make further recommendations based on the author panel's global experience in radiofrequency using a trans-isthmus approach, and discuss that with a moving shot technique, and discuss the requirements depending on the exact patient substrate as to what sort of monitoring is required during given ablation techniques, and have some diagrams relating to the optimal setup of equipment, and then provide various ultrasonographic examples of different lesions that can be treated with different forms of ablation, and discuss the utility of radiofrequency ablation in the setting of mainly mixed or solid nodules and primarily cystic nodules, being focused more on potential alcohol ablation. We discuss also the ultrasonographic anatomic considerations that are required. Yellow hour indicating the vagus location in the carotid sheath, and the red triangle being the danger area that is the position of the recurrent laryngeal nerve in the majority of cases. And then we look at move to post-procedural considerations. What sort of care needs to be provided? What sort of monitoring needs to be provided immediately after the ablation procedure, with recommendations relating to recommendation 10, that there are certain acute complications following neural ablation that need to be observed for, and that voice assessment is one of the parameters that needs to be assessed post-ablation. And in the setting of significant voice changes, then laryngeal exam needs to be obtained. In order to, with a good patient effect and high quality, enter into an ablative program at your hospital, so you need adequate outcome measures to determine measures of success, both unique to benign and malignant disease, and by procedure. We offer in table 3 a set of parameters, early, intermediate, and late, for adequate outcome measurement in the setting of benign nodularity, in the setting of benign functional nodularity, and in the setting of treating thyroid cancer. I think this is an excellent roadmap for safe and high quality ablation program, so that you can determine exactly how you're doing and the quality of your program. And recommendations 12 and 13 really relate to the careful documentation of specific measures for benign nodules, autonomous nodules, and malignancy when treated with ablative procedures. Incorporated in that set of objective outcome measures, recommendation 13B in the paper notes that patient-reported outcomes, validated symptomatic, cosmetic, and quality of life instruments can be useful in potential additional outcome measures for ablation in the setting of benign, non-functioning, or autonomous nodules, and list a series of qualitative patient-reported outcome measures that can be utilized or published and validated, that can be utilized in this space to determine patient-centered, meticulous post-operative outcome analysis with a patient-centered orientation. And again, sonographic measures that are typically utilized, and cytologic, histologic confirmation that can be utilized in the setting of malignancy. We also, given that the wide range of different ablative technologies that are available, as are listed in the left column, we give a author judgment as to the applicability of these different technologies in these different spaces, in these different diagnoses. Again, you see many technologies can be used in a variety of different settings, but there are some more suited to certain environments, such as predominantly solid benign nodules. Radiofrequency certainly would be strongly emphasized, whereas predominantly cystic nodules, alcohol ablation is certainly strongly favored by the author panel. However, you see there's a wide variety of options that are available for these different diagnoses according to our author panel. And then again, the potential complications and the summary and future directions will review. Again, really, recommendation 16 is again harkens to the development of a high quality program for ablation. Requires the assiduous recording of complications resulting from thermal ablation to optimally have an ongoing feedback loop to improve the quality of your treatment of these patients during these procedures. We do also discuss what might be reasonable considerations for training prior to the beginning of a radiofrequency program, and we discuss advanced training in a facility with ultrasound are essential, and that proficiency with ultrasound-guided needle biopsy is of great utility. The given provider providing the ablative technology should receive specific instruction in ablation in the chosen ablation technique, and that phantom models can be utilized as part of that training, as well as observation of cases. Optimally, one's initial cases could be observed by a supervising physician who is experienced in these ablation technologies, and that, again, long-term follow-up needs to be provided, whether the performing individual is a radiologist or surgeon or endocrinologist. All of these physicians may provide high-quality ablative procedures, but we do need to provide long-term ongoing follow-up. So that may be more applicable in one specialty or another, but there should be a provision, regardless of the specialty of the person doing the ablation. There should be someone, either that physician or one of their colleagues, who can provide long-term follow-up with ablation technologies. So we've reviewed the radiofrequency guidelines and ablative technologies from the Head and Neck Society and multiple other organizations from around the world, providing a framework. I think if you read this paper, you really will get a really strong advantage in terms of starting your own ablative technologies. I want to thank the TNT Association and Dr. Valcavi for his kind invitation. I'd like to provide an invitation of my own to our own Harvard Medical School surgical course, which will be virtual in November 2022. And also remind you of the World Congress has switched in 2021 to 3 virtual programs. We have a wonderful program committee that is hard at work creating additional virtual and in-person programming. We have a program actually coming up very soon on August 9th, which is outlined here with programming looking at Hürthle cell carcinoma, looking at worldwide thyroid cancer guidelines, looking at medullary carcinoma and RET-altered cancers, looking at new technologies relating to surgery, including monitoring radiofrequency and fluorescence, and also a tumor board with multiple major professor sessions. This is coming up soon. And I want to thank you again very much for your attention. I wish you a very pleasant, wonderful conference. Thank you.
Okay, thank you. I please Dr. Valcavi for the final remarks. Unmute your microphone. Go ahead. Thank you, everybody.
Thank you. Final remarks are the following take-home messages. RFA is a reliable tool for the treatment of solid benign thyroid nodules. RFA is also indicated in pseudocystic nodules and autonomously functioning thyroid adenomas. RFA has an increasing role in the management of low-risk micro-PTC, micropapillary tumors. RFA is well tolerated. Side effects are mild when a correct technique and when specific precautions are adopted. The operating surgical room is preferable to the ambulatory setting. This is under debate. Cold glucose hydrodissection is the mainstay to avoid inferior laryngeal nerve injuries. And finally, the proper best results are obtained when nodule ablation is complete. So to obtain complete nodule ablation is the mainstay of the procedure. I would like to invite you, next slide, please. Next. I would like to invite all of you to the second international meeting on thyroid ultrasound guided minimally invasive therapies, the second TNT meeting on June 24th, 2023 in Reggio Emilia, Italy. Please save the dates. We have a special, please note, we have a special offer reserved to webinar participants for 1 week until April 15th. Registration rate will be 150 euros instead of 250 euros. Enter the TNT Association website, which is downwards, but you can find the website, the TNT website, easily on the internet using the mailing address you will find thyroid.association@gmail.com. You will be contacted by the TNT secretary for further instruction. Thank you. Last slide. Thank you for participating in this superb, I would say superb webinar. Thank you for all to all speakers which contributed to the success of this webinar. And I invite you to follow the TNT Association and to join further TNT events. Thank you.